new options for people. And then in addition to my responsibilities as a genetic counselor, I actually also decided to run for the board of directors with the National MPS Society. So I get an extra little thing here, the purple one, for board of director. So I've been doing that for just, January will be 2 years. And I just thought it was, it was an organization that I really admired and had worked with for many years. And I saw all the good things they were doing, and my kids were leaving the nest. And so I thought, well, gosh, I have a little bit of extra time to give. And whoa, it is a lot of work, but it is very good. So I'm kind of here in 2 different roles. So I know we have an MPS 1 adult family over here. Tell me a little bit about your family.
We have an MPS 6. She is 15.
Oh, okay.
So we're trying to kind of figure, we're 10 years in diagnosis.
Okay, yep, same as you guys.
Yeah.
Yep.
So we're just, trying to figure out everything we can with that transition into adulthood and, helping her advocate for herself and learn to take over her medical care and things like, with our support, of course, but just navigating all the transitions that are coming.
Yeah, it's super tricky, as Nathan talked about earlier, for sure.
Yeah.
And then you guys are from Kazakhstan?
Yeah.
Oh my goodness, you came very far.
I am MPS 200. My name is Samad.
Okay, excellent. So MPS 2?
Yeah, MPS 2.
MPS
Nice
2. And you have a daughter? Did I?
Yes.
Okay,
Daughter.
you have a daughter, or you have a daughter. He
has
a daughter. Okay, awesome. All right, so we will address all of those things and inheritance and all of that. And I know some people in the room, this is all very new information too. So I will start at the beginning and not assume that people know everything already. We've heard this several times today, but I think it bears repeating. Mucopolysaccharides, my goodness, could they have picked a larger word for, for this? But it really is just those chains of sugar molecules that are actually used to build connective tissues in the body, and they're normal, they're supposed to be there. It's only when there are too many of them that it becomes problematic. And then really mucopolysaccharide is an older term. It's the term they used to use until they realized that they were really glycosaminoglycans, and then of course no one wants to say that either, so we just say GAGs for short. And then the thing to remember is that there are multiple types of GAGs, not just one GAG. And they talked about that a lot this morning as well. The one thing that is, from the genetic standpoint, makes MPS a little bit easier to diagnose is that we have multiple ways of diagnosing this condition. For some genetic conditions, there's only the genetic test. There is no other test. So sometimes we see a change in a gene, we're not sure what it means, so we kind of have to tell the family, well, you might have this or you might not. We have no other way of knowing. But with MPS, we do have the genetic test, which can be done on blood or saliva. We have the enzyme test, which in MPS would be low. That's always done on blood. That cannot be done on saliva. And then we have the GAG test. That can be done on urine or blood. Or cerebral spinal fluid, but we won't go there because who wants to have a lumbar puncture to get that? So just keep that in mind as we go along. And no mucolipidosis families, correct? So I will skip over that piece because it's a little different. So if we have the genetic test, what do those test results mean? So there are basically 5 different ways that a genetic test will report out a genetic variant. So in the old days, when I first started in this field, over 20 years ago, we called the changes in the gene mutations. Then we decided to become more politically correct because no one liked the word mutation. So then we started calling them genetic variants. And I think that can be a little confusing for families because you're just not used to hearing that type of word necessarily to know what it means. But I'll use the word genetic variants here. So we have genetic variants. We have these we've sequenced the human genome, so we know kind of what the average person's genome looks like. And then we sequence, say your genes, and we look at whatever gene is involved with the MPS in your family. And we see a change. Well, that change could be classified as a benign change. It could cause something called pseudodeficiency, which I won't get into here. It could be a likely benign change. That means, well, we think it's probably benign, but we don't really know for sure. A variant of uncertain significance, which is the worst one, let me tell you. And then who said it this morning? One of the speakers called it a, what did she say? I wrote it down. It wasn't annoying, very uncertain situation, whatever, yeah, I think that was it, very uncertain situation. And that's really what that means, like, it's a variant of uncertain significance, we don't know what it means, so that's what we have to try to explain to families when we get one of those. Then we have the variants that are likely pathogenic and known pathogenic. So sometimes I see a genetic change come in on a baby, and I'm like, oh, it's W402X for MPS 1. I know this is a classic severe variant. It causes classic severe disease. So just keep in mind that these are all the different ways that your genetic test results could come out. And then you'll have two of them, except for MPS 2, then you only have one. So you'll have two. One of them might be a variant of uncertain significance. One of them might be a pathogenic. They can be paired up in any way. For any of the MPSs, but mostly for MPS 2, you can have something called a de novo variant, and that's something that's not inherited, it just occurred for the first time in that person, okay? So what do these genetic test results mean? So as I said a little earlier, some of them we know a lot about. Some of them we know cause severe disease. Some of them we know cause attenuated or more mild disease. But sometimes we don't know. So then we look back to those enzyme results, we look back to the GAG results, and we can try to infer how severe things might be. Obviously, if someone's presenting, at age 10 or something like that, we have a little bit of an idea of how their clinical situation looks. However, a lot of times now we're diagnosing babies, and so we want to work hard to try to predict for those parents, because my goodness, how stressful. Does my child have the more severe form or the more mild form? The form that causes neurological disease or the form that doesn't? So it's not 100% reliable to look at those urine gags and the enzyme, but we do make inferences there. And then in this room, thinking you guys should know your genetic change. You're young enough to know your genetic changes. You guys are probably young enough in the journey to know, to have had genetic testing on a child.
No.
No?
Ours is unique only because she's adopted. So she's Asian and adopted from China, and so we have none of that.
Okay.
No health history for her,
Yeah,
no family
but
history.
she herself
so
probably had genetic testing.
To diagnose.
To diagnose,
yes.
yeah. So for older individuals, I have patients, usually they're at least like 18 or older at this point. They didn't have genetic testing necessarily, or they did, but it was in some paper chart, and we don't use those anymore. Those have all been sent to warehouses. So unless that family kept a copy of those results, they don't have them. So if anyone finds themselves in that situation and you're in the United States, there are actually free testing programs available now. You just swab your cheek, send in the sample, and for free we can tell you what your genetic variants are. Not free if you're doing carrier testing, but free for those individuals who are affected, which is really nice, and you don't have to go through the health insurance drama. Okay. So I want to review autosomal recessive inheritance because this is important in terms of understanding for families whose children and young adults who want to maybe go on and have children. So the inheritance is good to review. So as you guys all know, our bodies are made up of millions of cells. Inside the cells is our genetic material, okay? That genetic material is organized onto chromosomes, and then on that chromosome is thousands of genes. One of those genes, depending on which type of MPS you have, is involved with the disease in your family. So for MPS 1, it's the IDUA gene, okay? All of us have the IDUA gene. All of us have 2 copies of it. And those of us who are carriers, we have a pathogenic change in one copy, but the other copy is normal or regular, okay? So what happens is if you have a mother and father who are carriers, it's represented here. So this is the genetic change that causes disease. This is the normal. Each parent is the same. when you go to have a baby, the egg and the sperm, they randomly get one or the other for both, okay? So one or the other, one or the other. And then they come together. So there's 4 different ways that they can come together. So one way is for these 2 normal copies to come together. That's a 1 out of 4 chance. That child would be unaffected and a non-carrier. And then depending in these 2 cases, this is how you end up with a child who's a carrier. One parent gave the typical copy, the other parent gave the genetic change. And that means there's a 2 out of 4 or 50% chance of being a carrier. And then lastly, if these 2 come together in a child, it's a 1 in 4 chance to have a child with the condition. Okay? So that's for every type of MPS except MPS 2. So what you'll see with autosomal recessive conditions, I think this is sort of important to know. Males and females are affected in roughly equal proportions. Affected individuals are usually siblings in one generation. You don't often see affected individuals elsewhere in the family history, okay? Most people say, well, this was never in my family. How did this happen? That's the first question I get when I meet with a new family. Carriers are unaffected, they're healthy. And we talked about that 1 in 4 chance. And then unaffected siblings, so say you haven't done any testing yet, but you know your affected child's siblings are unaffected. So you get rid of this chance. You know they're unaffected, you know they don't have the disease. That leaves a 2 out of 3 chance to be a carrier, okay? Some people think it's 50%, but it's actually 2/3. So it's more likely than not that your siblings are carriers. Okay. All right, and then moving on to Hunter syndrome is X-linked. So we all have most of us have 2 sex chromosomes. We have an X and a Y, either if you're male, an X and a Y. If you're female, you have 2 X's. So we have more genetic material, ladies, than the men. And I have 2 different scenarios here. So we'll start here with an unaffected mother who is a carrier. Okay, so this is her copy with the genetic change that causes disease. This is the copy, the normal copy. Or sorry, I have that reversed. This is the normal, that's the affected. And what happens in this scenario is mom can only create female children. It's dad who determines the gender, okay? So if dad gives a Y, you will always have a male child. And if dad gives an X, you will always have a female child, okay? So for those dads who blame the mom for having the wrong gender child, not her fault. So all of this depends on if mom passes the X with the variant or the X without the genetic change, and it depends on the gender of the child. So we'll go through the exact numbers on the next slide. And then if you have an affected father, well, whenever he gives an X, that will be a what gender child? Female. And that female will not have Hunter because females don't have Hunter because they have that extra backup copy. However, all the daughters will be carriers because that's all he can give, okay? If he gives the Y, well, goodness, that works out because you have, he can't ever give a son. It will always be a boy, and he can never give a son the mutation. So he will never have an affected son. So our X-linked rules are that X-linked recessive conditions are usually only present in males. You may see other affected individuals in the family history because you're passing it through those carrier mothers. So sons of female carriers have a 50% chance of being affected. Daughters of affected males are all carriers, so 100% chance they're a carrier. And sons of affected males never have the condition. There's a little bit of an unusual situation with X-linked conditions. We know that without a family history, there is only actually a 2/3 chance mom's a carrier. There's a 1/3 chance that this is de novo, and this child is the first genetic change in the family. So we have to test mom to figure that out. And then there's this, yes, go ahead.
Are you saying that for all X-linked or just for,
It also works with several other X-linked conditions, yes. So, like Duchenne muscular dystrophy is another one that it's sort of a general X-linked rules. There are exceptions, but it works for a lot of the X-linked conditions.
Sorry. 1 minute.
Yeah, go ahead. And then if mom tested in her blood or on a saliva swab is negative, there's actually a chance that some of the cells in her ovaries might contain the genetic variant. I know, right? Could it get any more complicated? This does not happen in the recessive conditions. And so there's always this residual, even if she tests negative, 1% chance to have another child with Hunter. And we learned that by experience. Okay. And then if a mom is a carrier, we want to keep in mind that her mom could be a carrier, and we wouldn't know unless we tested, and her sisters could also have a 50% chance of being a carrier, okay? So lots of X-linked rules. And then just to throw a new twist into the story for MPS II, we started screening in Ohio for MPS II in October. And Illinois has been screening for many, many years already, so they've seen this. And now my first case that I just had, what it turned out to be, even though the child is affected and there's a genetic change there that was seen in an individual reported to have MPS II in 1998, his biochemical testing is consistent with MPS II, but his enzyme is very low, but his GAGs are not very high. We did family testing and we found out that his grandpa has it, but it's just very mildly affected. So as we start mass screening all babies born in the US, I think we're gonna find more of this. So we have to be very cautious when we're counseling these families. We don't wanna scare anyone that their child may have a severe form of the disease when in fact their grandpa might have it. So we need to go through the motions and make sure we're doing this family testing. So crazy times. But it does enable us to predict that likely this baby that I have sitting in front of me is probably going to be very mildly affected, if at all. So this is a picture of a family tree. Circles are females, squares are males. And this is for an autosomal recessive condition, so not X-linked. And what I just wanted to show here, because it's happened to one of my MPS III families, people always ask, like I said earlier, how did this happen? This wasn't in my family. So this is exactly how it happened. So here, carriers are represented with that light pink dot in the center, okay? And then affected individuals are those with that little red square in the top left corner. So as you can see here, we have 2 affected individuals, and they're separated by a lot of people. So you can envision that in this family, over here, they had this affected individual with MPS, and they told these people, they told these people, and a lot of people there probably got carrier testing. And then the rates for carrier testing drop off over here. But that doesn't mean that those people aren't at risk to be carriers. You can see here that it all started up here with this individual, and 3 of his 6 children actually were carriers. And then over here, we see that this carrier has passed it on to her son. And then it turns out that he happened to, have a child with a woman who was also a carrier. Now, these conditions are rare. We don't expect that to happen very often, but I did have it happen with a Sanfilippo family where 2 of my patients are distantly related cousins. So this is where I put in my plug to say, share your carrier status, let your families know, because they can get tested and find out. And if their partner gets tested and isn't a carrier, that's great, it's wonderful. But this is how recessive diseases hide in families for many generations before an affected individual is born. Okay, not to scare anyone. We're all carriers of something, as I think is probably, yes, literally my next slide. So what can we do about being a carrier? So most of us are carriers of about 4 or 5 different recessive conditions. It's just we haven't met someone who's also a carrier and had a child with them, so we'll never see it. Or maybe we're both carriers, but it just so happens when we had kids, they were the 3 out of 4 that weren't affected. So it can really travel through families, all different conditions. So in 2025, we have something called broad-based carrier testing, okay? So we can now test for up to 600 different recessive genes in one saliva sample or a blood sample. So that cost is about $350 if you just pay up front and don't go through your insurance. And that is the same cost as testing for the one gene in your family. So something to be considered, right? That we could be looking for 600 or we could look for 1 for the same cost. So carrier testing, there's a lot of different genetic tests out there, and it gets really confusing for families who are pregnant or considering a pregnancy. And the OBs don't do a fabulous job of explaining all the intricacies. So carrier testing is different from the gender test. So you probably hear about people who find out between like 8 and 10 weeks of pregnancy if they're having a boy or a girl. That is called That's called NIPT, or non-invasive prenatal testing. That's a blood draw during the pregnancy that can tell you not only the gender of the baby by looking at fetal cells that are circulating in the maternal blood. It will also give you a risk number for if your baby might have a chromosome abnormality. So that's totally different from recessive conditions like MPS. So the most common example of a chromosome abnormality is Down syndrome, okay, caused by a whole extra chromosome number 21, which has a ton of genes on it, and you have a whole extra chromosome. So that's what's found on that test. Carrier testing is also not your 23andMe testing, your Ancestry.com testing, counselor sequencing.com. Those are really for entertainment purposes only. There are so many, they are not like certified for clinical use, and there have been many, many reports of incorrect, inaccurate results on those tests. People thinking they have the gene that causes breast cancer, when in fact when you repeat the testing in a real lab, they don't. So just keep that in mind. I know it's super affordable, and some people have found, like I had a patient who found out she had Gaucher disease on 23andMe. So it can be useful in certain situations, but it wouldn't be what I would consider like clinical grade testing. So carrier testing and what you get offered can depend where you live, which really stinks and is not, I don't think, fair. I worked in New York City, and all the patients had carrier testing. All the OBs offered it. I moved to Cincinnati, Ohio, and no one is hardly ever getting it. I have so many families that walk in, I'm like, they have an abnormal newborn screen, and I ask them, have you had carrier testing? Like, so we can help figure out if, you know, maybe this is a false positive. And they all tell me, I don't even know what that is. No one even offered me that. So it's very interesting. But so you can always advocate for yourself about getting expanded carrier testing. Your OB can do it, or you can go to a genetic counselor and get it done that way. Let's see. If for some reason you're going and doing in vitro fertilization, most IVF centers will offer this. My only caveat is make sure it's a larger panel. My most recent patient came in and she had carrier testing. Guess how many conditions were on that panel? 12. So was the gene that her baby screened positive for on the newborn screen on that? No, it wasn't. But had she gotten, she had asked for the expanded one too, and they accidentally ordered the wrong test. And here she was, having gone through in vitro fertilization due to fertility issues, and could have tested the embryos had they known, you know, that if they were both carriers, and they didn't get the right test accidentally. So that was very unfortunate. You always want to make sure if a family member is getting carrier testing that the panel that they're getting contains your family's gene. Most large panels will include all the MPS genes, but just, you know, make sure because you don't want to have a test that doesn't include that gene. And then, and make sure that that test can detect the variant. One of our board members here has a variant that's super tricky to find and requires different technology, some more expensive technology. to detect, because it's in a different part of the gene that we don't normally look at. And, you know, we're not gonna find stuff like that on the regular test, but when her family members go to get testing, they need to make sure they're having the right test that can identify their family's gene change. So things to keep in mind. So we're kind of switching topics now. Any questions on anything I talked about so far? Yes, Mary.
I'm wondering if you could very briefly talk about pseudodeficiency alleles for carriers.
Yes.
We get a lot of questions of that and the pathways from like family members that get testing or partners and
Yeah.
just.
It's the pseudodeficiency alleles. Again, one of these things where someone came up with like the most hardest word in the world to name something. But basically all it is a what we call a benign or non-disease causing change in a gene. And what we know about these now, and we've discovered this really through newborn screening, is that some of us carry benign changes in the gene that make our enzyme look low in the test tube, in the lab, when they're using artificial substrate. But when it's in the body, it's working completely normally. So your enzyme looks low in the test tube, and so you might come to attention and have a low enzyme level on a newborn screen. But then when we test your genes, we see that you carry this known pseudodeficiency allele, and we can say, oh, I know your enzyme looks low, but we don't have to worry because it only looks low because of this pseudodeficiency allele. We also do GAGs in those babies and make sure they're normal, and they are, so that's good. That phenomenon, to my knowledge, does not occur in MPS 6. So, but we see it a lot in MPS 2, MPS 1. Not San Felipe that I'm aware of, but of course we're not newborn screening. So. Yeah, so just keep in mind that pseudodeficiency alleles are benign gene changes.
And when a partner is a carrier and you're a carrier of a pathogenic or disease-causing one, there is no risk to have a child with that recessive condition.
Correct, yes.
Just
You may
thinking
get
of
flagged on the newborn
partners.
screen,
Yeah.
but you'll turn out it'll be a false positive. So. Okay, and so we're fortunate enough, and I think Nathan Grant said this earlier today, that our individuals with MPS are living longer lives and considering childbearing. So for individuals who've had transplants, which I don't know that that applies to anyone here, you know, historically these individuals are often told, you know, well, you've had a bone marrow transplant, you probably are not fertile due to the chemotherapy that you received as a baby. However, I would like to tell you that bone marrow transplant, while it can affect fertility, it is not a method of birth control. So keep that in mind if you've had a transplant. So if you want to not be pregnant, you probably want to use birth control. And then you can certainly check with your providers who can run various tests to determine your fertility potential. And now in our babies who are having bone marrow transplants, both male and female babies are offered fertility preservation, where they freeze testicular tissue or ovarian tissue that could be used later in life to have a biological child. Okay. Now, in 2025, it's kind of exciting because we have so many different options if we're carriers or affected with a condition. So, certainly I've had many families who have just said, you know what, we're gonna have a natural pregnancy and we're either gonna check while the baby's in utero to see if the baby's affected or test the baby after birth.
Yes,
Certainly a viable option. I've had families go through adoption instead of doing natural pregnancy. And then I've had families that undergo testing during the pregnancy to see if the baby's affected. There's actually something out there called embryo adoption. A lot of people haven't heard of this. Basically, there are lots and lots of embryos created by the IVF process in fertility centers. And you know, you might create 10 embryos and then you have 4 children and you've got these leftover embryos. And families will donate them to other families. So it's really a wonderful resource, especially for families that can't necessarily afford the IVF process. And so that is also an option. Sperm and egg donor. A lot of people don't take this one seriously, but sperm donation is probably one of the cheapest options to achieve a pregnancy that is not at risk for MPS. So if both parents are carriers. Really, it's very minimally invasive for the female, and you choose a sperm donor from an online bank, and you get to pick what they look like, what color hair they have, how tall they are, how far in school they went. Like, I assume they have photos. I mean, they must. Yeah. So, and you can pick the same donor for all your pregnancies, and it's again very minimal invasiveness for the female partner. I know a lot of people don't like to do that. They want to use their own genetic material, but it is out there and it is relatively affordable as an option. Using an egg donor is way more invasive and way more expensive. So that option, I don't know anyone who's done that personally.